And like you discussed earlier, the distance in which we can now run with these treatments before patients ever need to come to our infusion centers and need to have a port installed and have all the detrimental effects that come with any form of IV therapy, is it an ADC or actually chemotherapy, I think is really incredible, and new. It's not that we've been dealing, with endocrine therapies that brought women many months and even years of quality of life with metastatic disease.
Yeah, and I applaud people who have broad practices that don't just see breast cancer like we do largely, because it's challenging enough for us to sort through all the new data that comes at 4-month to 6-month intervals, depending on which meeting you're going to. So I think that this is a good time to be in oncology, but it's also a very challenging time to decipher and interpret all the data.
Yeah. So when you talk to community oncologists that do breast cancer also as part of their treatment, what kind of questions do you see about data sets like that, and in terms of, how incorporating a molecular profiling? I feel like in my practice, where I work with a lot of physicians who are subspecialized like me, but do other things, say lung cancer, I feel like the whole concept of molecularly subprofiling a tumor is very intuitive for my colleagues who treat multiple myeloma or lung cancer, right? So in a way, yes, as much as it is groundbreaking for us in the breast cancer space, I feel like for many community oncologists, this might actually be more intuitive than we think.
Oh yeah, I think they're ahead of us. I mean, breast cancer was slow to the party.
Right.
The people in lung cancer and the other disease sites have been doing frequent molecular testing for a long time. And they were really, I think this is just, as you said, intuitive to them. So if it's useful information in lung cancer, why wouldn't this potentially be useful in breast cancer? And again, the link that you have to have is, it's one thing to show you have an abnormality. It's the second important link is having a therapy that addresses that.
So true.
And finally, we've caught up. So we have a number of different drugs. So one of the common things that I think, forget community oncologists in general, are going to be challenged with is having several different options within the same space and understanding what's the best drug based on the data from individual trials that aren't all identical and how they were developed. So that's going to be challenging for all of us.
But again, to your point earlier, what a great problem to have, right? Because it used to be endocrine therapy, and then if you progress, you went to chemotherapy, and now we have so many multiple lines that are actually directed to the patient's disease, and not just another, shot in the dark attempt of, well, we'll see if your disease will respond to it.